Today, I would like to focus on gastrointestinal ultrasound. Unlike solid organs, the gastrointestinal tract requires a dynamic and layered approach. The key concept here is wall stratification. If we understand the normal layered architecture, we can recognize pathology early and with confidence. Let us begin with anatomy and scanning technique. The anterior wall of the stomach lies in close proximity to the left hepatic lobe, while posteriorly it relates to the pancreas and splenic structures. A transabdominal approach with great compression is essential. Gentle progressive pressure displaces intraluminal gas and improves visualization of the wall. This is particularly important in gastric and colonic assessment where air frequently limits acoustic penetration. In a normal condition, the gastrointestinal wall displays a characteristic five-layer pattern, alternating hyperechoic and hypoechoic layers. From the lumen outward, we identify the hyperechoic interface of the mucosa, the hypoechoic muscularis mucosae, the hyperechoic submucosa, the hypoechoic muscularis propria, and the outer hyperechoic serosa. Recognizing this layered structure is fundamental. Any focal or diffuse loss of stratification is a red flag. In adults, the total thickness of the gastric wall typically ranges between 5 and 7 millimeters when examined without peristaltic contraction. The muscular layer alone should measure less than 5 millimeters. These reference values are important in distinguishing physiological contraction from pathological thickening. And now, let us move to neoplastic disease. Gastric carcinoma often presents as a localized thickening of the wall with disruption of the normal stratification. The wall becomes hypoechoic and irregular, and the lesion may protrude into the lumen or infiltrate outward. An important indirect sign is impaired gastric emptying with luminal dilation proximal to the obstructing lesion. In advanced cases, the thickening can be diffuse and circumferential as seen in infiltrative processes such as lymphoma. It is crucial to remember that posterior gastric wall lesions may be partially obscured by intraluminal air. In such cases, correlation with endoscopy or cross-sectional imaging is often required. And now let us address inflammatory bowel disease, particularly Crohn's disease. Under normal conditions, the small bowel wall is thin and often barely appreciable. In Crohn's disease, however, we observe marked wall thickening, often exceeding 3 millimeters, with reduction of the luminal diameter. In transverse sections, the thickened segment may display a concentric target or cooked appearance. Unlike neoplastic processes, Crohn's disease frequently preserves some degree of wall layering, although it may become distorted. Color Doppler plays a crucial role here. Active inflammatory segments demonstrate increased vascularity within the wall, reflecting hyperemia. This hyperperfusion is a useful marker of disease activity and can assist in therapeutic monitoring. Complications must always be actively searched for. Fistulas appear as hypoechoic tracts connecting affected bowel loops to adjacent organs or the skin. Abscesses may present as a fluid collection with irregular walls and internal echoes. Identifying These complications early significantly impacts clinical management. Intestinal intussusception represent another important entity, especially in pediatric patients. Sonographically, it appears as concentric rings in transverse section, the classic target sign. Recognition of this pattern allows prompt intervention, often non-surgical in early stages. Moving to the colon, diverticulosis is common, particularly in elderly patients. A diverticulum appears as a small outpouching communicating with colonic lumen through a narrow neck. In uncomplicated diverticulosis, the surrounding wall is usually normal. However, in diverticulitis, we observe focal wall thickening adjacent to the diverticulum, blurred pericholic fat, and sometimes small pericholic fluid collection. The pericholic fat becomes hypoechoic due to the inflammatory changes. In more advanced stages, abscess formation may occur. Appendicitis deserves particular attention. In normal conditions, the appendix measures no more than 6 mm in external diameter, with wall thickness under 2 mm. It is blind ending and non-peristaltic. In acute appendicitis, we observe a non-compressible tubular structure exceeding 6 to 7 mm in diameter, with wall thickening and surrounding inflammatory changes. Periappendiceal fat becomes hyperechoic, and in complicated cases, fluid collection may be present. Finally, differential diagnosis is critical. Not all wall thickening is Crohn disease. Ischemic processes, celiac disease, infection colitis, and neoplastic infiltration may produce overlapping sonographic findings. Therefore, interpretation must integrate wall thickness, stratification patterns, vascularity, distribution, and clinical context. In conclusion, gastrointestinal ultrasound is highly operator dependent but extremely powerful when performed systematically. Understanding wall layers, applying graded compression, assessing vascularity, and correlating with symptoms allow us to differentiate inflammatory, obstructive, and neoplastic conditions with high accuracy. For a clinical application specialist, mastering these principles means not only explaining how to acquire images, but guiding clinicians toward confident, evidence-based decisions at the point of care. Thank you for watching.